where bold women and big ideas meet. Only on Pink Perspective, Spice FM.
All right, Becky. It's time for the masterclass. But before we get to the masterclass, allow me to mention that the mood reset was none other than Alicia Keys. It was really good. We danced. We had Karma. We had A Woman's Worth and Unbreakable. And Joyline, kudos. Yeah.
My kind of music. Thank you, Joyline.
Yeah. All right.
Alicia.
Becky, do you want to usher us into the masterclass?
Yes. Now we are about to have a conversation on the masterclass. And our guest today is not so new to this show. But she's such a brilliant lady.
And funny.
Oh yeah, your sense of humor. Because we found ourselves laughing after you had left. You're like, okay, wait a minute, what was that?
She's so funny.
Yeah, very nice. So thank you so much. We have Dr. Maureen Owiti in studio today. She's a gynecologist, an obstetrician gynecologist, who's going to help us understand fibroids. Mtu anasemangaje daktari, ni fibroids ama fibroids? Potato. Fibroids.
As long as we're on the same page.
Yeah. But let's start with the question first of the of the day first. The first question is, what's your pink today? What's that one bright thing today?
My pink today, I think, I'll just say I'm just grateful to be alive today.
Yeah.
We're at an age whereby you just hear so and so has passed. And see somebody, you're in school with them, you're in class with them. So mine is just, I'm just happy to be here.
Oh, that's beautiful. That's a beautiful pink. So fibroids are one of the most common women's health issues, but many women still misunderstand the condition, and that's why we decided to have this conversation today. They misunderstand it until probably the bleeding part, or it affects their fertility, and you're going to tell us about that, and it affects their daily life. And I've personally just seen a lot of women go through a very hard time, because of fibroids. And I think it's a very good conversation to have at this time, for us to understand, for women to understand what they need to look out for, what they need to know early, when they need to seek help, and of course the treatment options that are available. So let's start with the top question, what are fibroids, Daktari, and how different are they from other, say, uterine conditions? What are fibroids?
Okay. Yeah. So personally, I say fibroids.
No, fibroids. Okay, I'll pick that one.
No. We had agreed potato. Whatever works for you. Okay. So personally, for me, it's fibroids.
Okay.
So I think for me, the key message is the word benign. Okay. Meaning they are not cancerous growths. So I think just to really make everybody, relax from that point of view.
Yeah.
But it's understanding that because for us, any growth we call tumor. The moment I mention tumor, everyone thinks, I have cancer, I'm going to die. A tumor just means a growth, and a growth can be either benign, non-cancerous, or cancerous. Okay. So fibroids tend not to be cancerous in majority of women.
Yes.
Just for stats, on average, only 1 in 2,000 cases of fibroids. In fact, the number is 1963, but whatever. So 1 in 2,000 cases will have a cancerous transformation. Okay. So generally, it's a benign condition. However, it gives very, very bad symptoms. Now, which part of the world are we in? We're in Africa. Okay. So what is unique about Africa? For whatever reasons, there's a genetic predisposition for fibroids.
Oh, really?
We don't know what causes them. Okay. But Africans have the highest incidence of fibroids. So whether it's African or African American, African, whatever, but you have some African ancestry, you're at actually a higher risk for fibroids. So I think it's very opportune that we're having this conversation, because this is something that affects us as African women. Okay. So again, back to the question. So it's a growth, and it comes from the muscle. The uterus is a muscle. So it comes from the muscular wall of the uterus, and grow. We don't know what causes it.
Wow.
And the person who discovers that may win a Nobel Prize.
Yeah.
It could be you.
No.
Could be you.
I'm very clear on the research and development. Me, I'm an implementation science.
Okay.
Let other people tell us what to do. Me, I figure out how it reaches the person down on the ground and how it's going to be useful to them.
Yeah.
So again, a very useful part of the research arm. So their growths, they come from the muscle of the uterus, and they can be anywhere. So unfortunately, no two fibroids are the same. Yeah.
Oh.
So in as much as the disease sounds like it's one thing, you know, like when I say somebody has malaria, we're very clear. There are malaria parasites in the blood. They're gonna have fever, diarrhea, vomiting, all those things. It's uniform. Okay.
Yes.
How they experience. So it's just the severity of the symptoms that changes.
Yes.
But no two fibroids are the same. Reason being, the uterus, like if you look at it in 3D, the fibroid can be on the outer layer, it can be on the inner layer. Okay. You can have 1, you can have 100. You understand? So obviously, though, every patient is going to come with their own unique presentations. So on that spectrum, so the three of us can have fibroids, but you'll have heavy bleeding. You understand?
Okay.
You can't urinate.
Oh.
I'll have no symptoms. And we all have fibroids.
Wait, you have, is it? What? So if you say that you have no symptoms, then how is it diagnosed?
No, exactly.
Yeah.
So some people are very good at health seeking, so they go for general checks. So there's that person who just incidentally, I went for routine screening, for whatever reason a scan was done, and voila, there's a fibroid. Or you went in for, let's say you had a back issue and maybe a CT scan or MRI was done, and voila, you see there are fibroids, but you have absolutely no symptoms for the fibroids. Okay.
Goodness.
So for us, fibroids, we come in when now a patient has symptoms for these fibroids. Yeah.
Okay. Wow, I did not know that.
I also didn't know that. And I don't want you to get into those symptoms. Could you talk about the symptoms, like the different symptoms and how it presents itself?
Okay. Yeah. So for personally, in my practice, I think the most common symptom we tend to manage is bleeding.
Okay, bleeding.
Okay.
Bleeding that is unusual to my monthly period.
Yes.
Okay.
So, and I really like that because anyway, that's a story for another day. I can rage bait. You know, sometimes your colleagues annoy you, but it's okay. You just say it's fine. So, women, normally we have periods. So if you have your periods, there are those people who are lucky, they bleed G 1 day, 2 days. There's the rest of us, normal people who have the 3-4 days. And there are those who even have 7 days. But definitely, when you're going more than a week, obviously that period is a bit on the longer spectrum. So with bleeding, how we'll notice is, like, for example, if you have a 3-day cycle, all of a sudden your period starts coming 4 days, 5 days, 7 days. Okay. And then there's the amount of flow. Okay. So you used to use 3-4 pads or 3-4 tampons in a day. All of a sudden you find you need 8, even a whole packet for a whole day. So it's heavy bleeding. Okay. And this heavy bleeding in some patients can even lead to symptoms like severe headache, fainting spells. Okay.
So they're anemic.
Yeah, because they're anemic. They're now anemic. And so that would be the most common reason why we deal with fibroids. Other symptoms obviously will be like remember I mentioned, like, you're having pain. Okay. So for a lot of people also pain is an issue. Then others, it will be now mass effect on the size of the uterus. So you find the uterus is in very close proximity with your bladder, urinary bladder in the front, and your rectum
in the back.
At the back. Okay. So urinary bladder, it can either present that you're having difficulty urinating, or so you need to urinate all the time because you feel like
the blood is
always full all the time. So either of this, and the same with the rectum. Either you'll be constipated, or you feel the urge to always need to go
to the bathroom
all the time. Okay. So and the last is cosmetic.
Okay.
Yeah. So this person, and remember, fibroids is very common. I said, so first of all, being African is a risk factor. Then if I remove race, because it affects all races, I don't think there's any race that we've known don't have fibroids. So if we remove race, another common factor is when women don't use their uterus for the purpose God gave it, which is having babies.
Yes. Yes.
I know an argument for another day, because there's some child-free vibe. Okay. I'm sorry, I don't understand. And to those people who are in those, it's fine. I believe everybody has their brief in life. I think what I tell people is I don't have to understand. You understand? I just need to respect your choice. Yes. Okay.
Yeah.
So as I've said, I don't understand, but I respect their choice. Yeah. So the work of the uterus is ideally to carry a baby.
Yes.
Okay.
Yes.
So when you find women either are not having baby or they stay for a long time without getting pregnant, that's when the fibroids start coming.
Yes.
Okay. So that's another risk factor. So nuns, you find nuns tend to have a lot of fibroids. Yeah. And people who, for whatever reason, choose not to
have
or are unable to. Remember, infertility can be a cause, like you want, but you're not able to have children. So you're staying for long periods of time. So even you can find somebody, I gave birth at 18, and then whatever happened, I decided I want to do other things, wait for 10, 20 years. Obviously, in that period, you're going to get fibroids.
Yeah. So there's always that say that they cause infertility. Is that like fibroids?
It's a big debate. Okay. And again, fibroids are a factor of one. The most important factor for fibroids is location.
All right.
Where they're located in the uterus. Yeah.
So if you find like the uterus is like a sac, okay? So the inner lining, okay? So if you find a fibroid in the inner lining, those are related with the possibility of infertility. Okay. So it acts like a coil, okay? Or it helps, like you can actually conceive, but you miscarry because there's no space for the baby to grow.
Yeah.
Okay. Vis-a-vis, same person, same size of fibroid on the outer wall of the fibroid, those are not going to have any symptoms. So their only symptom would be when they have many fibroids and the uterus has grown.
Yes.
So everyone starts asking you, hey, when are you giving birth? And that time you're not even pregnant. Yeah, because the uterus can grow. I think I've had patients who they look like they're about to give birth.
Oh no.
And they're not pregnant. It's just fibroids have filled the entire abdomen.
Wow. And Dr. Let me go back to the previous statement that you made about, for example, nuns being likely to have fibroids. But then you also mentioned that a certain girl like myself could have maybe given birth at 18 and then decided to wait another 10, 20 years. So is there an age factor here that we could bring up?
It's not so much age, it's just so much, is your uterus doing its work? And then remember, in as much as I've said it's more common in Africans, it's not to say that all Africans are going to have fibroids. So if you have like a family predisposition to it, and obviously you're staying long, then you'd have a higher risk of developing fibroids.
Okay.
When you talk about the bleeding, so and you know, like it's different from the normal periods. This is like from a doctor's perspective. What is it that is bleeding? Is it the fibroids, or what effect is there that would cause the excess bleeding?
Okay, so I don't know how to explain this, but we're talking about surface area. Okay, so remember, like the inner lining every month gets ready for
shedding.
The work it gets ready for ovulation, for implantation. It prepares itself for implantation. So during the course of the cycle, you find that, after it has shed, it'll first grow, and then it's going to have some changes which prepare it to accept the fetus. Embryo. At that point, it'll be an embryo, okay, for implantation.
Okay.
And when that doesn't happen, okay, it's like, I'm not pregnant, signals, it sheds off. Okay?
Yes.
So what a fibroid is going to do is that if it'll be a normal uterus will have a small surface area, but a fibroid is going to increase because you have plus the shape of that, and all that is going to have had the lining grow and shed off. So it's just you have a larger surface area.
Okay.
So because you're bleeding from a larger surface area, the bleeding is more.
Oh,
yeah.
Well, that's a good explanation. I think I see it now. Dr. Ari, let's talk treatment. And maybe you can advise us here on the treatment options that are available today. Is it just medication? We can talk about surgery. And most importantly, because we live in this African system, herbal medicine.
Okay. So, if I was a herbalist, I would discuss herbal medicine. So my disclaimer again,
yes,
and with all due respect to the herbalists out there, it's not an area I'm familiar with.
Okay.
So I am not going to advise for or against, because it's not an area I'm familiar with.
Okay.
Personally, let us do what the conventional
treatment, surgery and medication.
Okay.
Yes.
So that's what I'm going to delve into.
Please do.
Yeah. So any disease, even cancer, your first option, and you should always be told, is no treatment. Okay? And you must be given a right to express that. Okay? However, if you want no treatment, what are the effects of no treatment? The effects of no treatment is that the disease is going to progress. Okay. So if your symptoms are bleeding, your bleeding is going to get worse. If your symptom is pain, it's going to get worse. You understand? So and remember, if it's a swelling, it's going to grow. It's going to get bigger. So and again, I think I also like that question about age. You obviously are going to look at 3 arms when you want to treat a patient. Okay, maybe 2 arms. Okay, let's wait 2. Okay, so the 2 arms. No, I'll put it 3 again.
Okay,
is what is your desire for future fertility?
Okay,
it's a consideration. Okay, what are the symptoms we're treating, by the way? Okay, and the age of the patient.
Okay,
so you find like you could be 45. You have your 2-3 kids. No. You don't want, you wanted 2 kids, you have your 2 kids, so you've finished your you have your desired family size, so you technically do not have need of your uterus for future treatment. So treatment plans is something we're going to discuss with the patient and taking into consideration those factors. Because at 45, again, depending, if the bleeding is not very severe, or your pain is not, your symptoms are not very severe, what's happening around 45?
Menopause nimepita.
Will be menopausal, perimenopausal.
Yes.
And what is the beauty about going into menopause, perimenopause? We know, and what has been shown by science is that when we go into menopause, your fibroids are not going to shrink.
Wait, say that again.
When we go into menopause, our fibroids will shrink.
Okay.
Meaning, and remember, menopause, meaning you'll stop periods. So if your symptom was bleeding,
then definitely it's going to stop. Okay.
You get? Okay, if your symptoms were pain, they're shrinking because they shrink less these inflammatory markers and those pain thingies. So it's going to be less.
Okay.
So age will be important. Your desire for future fertility important, and the actual symptom will be important. And we have that discussion. What are the various options, and we go that way.
Okay.
So broadly, so that we don't go into, because even most of the treatment options will manage a lot of the things. Okay.
Yeah.
So we start with medication. Okay. So we have various classes of drugs.
Yeah.
So some will manage pain. So like your diclofenac, we call them NSAIDs. But interestingly, they also reduce bleeding.
Oh. Okay.
In some patients. Okay.
Yeah.
So you can do that. Obviously, and remember, there's the bleeding, and then there's what's associated with the bleeding. So, for example, if you're anemic, we need to boost your blood levels.
Yes.
Okay. Yeah. So obviously, we'll give you something to either a blood booster, and if it's in very severe cases, we've had to admit patients for actual blood transfusions.
Oh, wow.
Yeah. Now, by the time I need to admit you for a blood transfusion because of fibroids, it means I need to be more aggressive in terms of your actual definitive management for the fibroids itself. So again, severity of the symptoms is going to matter. So it's not like a conversation that, you have fibroids, take Panadol and we're done. No, it's all these things come into play to make us come with a decision on what's the best course of action for this patient. Okay.
Yeah, Dr. And as you're saying that, I'm very curious and worried, concerned, just like our listeners, I'm sure. Is there a risk of fibroids recurring after treatment?
Yes.
No way.
Okay. Yes, ways. So we'll go into that one so that. So it's, remember, the only definite treatment for fibroids, 100%. You're not going to get fibroids again, is only one. And it's what I think Becky told us at the beginning of the show. And that's to remove the uterus. That's a hysterectomy. Okay? Yeah. Because once the uterus is not there, we don't have where the fibroids are going to come from. Any other treatment will be like for some time, over time, other fibroids are going to come back.
Oh my God.
Okay? So it's understanding that also. But you see, you're 20-something with fibroids, don't have kids and like to have a family. Am I in my right mind going to do a hysterectomy for this patient also? No. So again, the age, future fertility, symptoms, all of that, they just come into play.
I see that.
So I think we've talked about blood boosters, we've talked about pain medication. Then we go into hormonal treatments. So for some people, progesterone therapy does work and helps reduce the bleeding during the periods.
Yes.
Okay. We also have some special class of drugs which also just help to reduce the bleeding during the periods. Even like something as simple as even a combined oral contraceptive for some people, if they don't have very severe cases, could work. On progesterone, we have a coil. It's a special coil. We call it a levonorgestrel containing coil, popularly known in this part of the world as a Mirena. I think that's the one that's readily available in the market. Okay, so that would drastically reduce the amount of bleeding without the need for surgery. Okay, and again, remember, treatment, we start, we see it's working, cheers, not working, can we try something else? Then for some patients, we would have to opt for surgery. And again, surgery will be, do we remove the fibroids only? Do we remove the uterus
as well?
Okay. And then for both modes, where, like, if we're removing it can be either an open surgery, okay, and again, or it can be laparoscopic surgery. So that's the keyhole surgery where we don't open and we operate with cameras. Okay? Yeah.
Okay.
Yeah, and it's readily available at least in Nairobi and Mombasa.
Okay.
Yeah. So there's hope of robotic surgery soon coming in the country. I'm not sure. There could be a facility that has it, but I'm not quite sure if they've started operation as yet. And then you go to other less invasive approaches. Okay, so from radiology, they have what is called the uterine artery embolization or uterine fibroid embolization. The only challenge with that to date for people with desire for future fertility,
Yes.
may not necessarily be preferred mode of treatment.
Okay.
How does it? What does it do exactly?
So what it does is you have the interventional radiologists. They have special catheters, just like the way they do this balloon surgery for the cardiac, like people with heart attacks and stuff.
Yeah.
Now they pass those catheters, they put it through the veins in the thigh or the lower limbs, and they pass. No, it just goes through that. They're very thin. It's like a wire. It's a wire or a catheter. And they direct it all the way to the arteries that supply the uterus. We call the uterine artery. Okay. And then they have special pellets, which they're going to release at that place, and it blocks the uterine arteries, because what is been shown is that fibroids exclusively get their blood supply from the uterine arteries.
Okay.
So the uterus itself, however, it gets blood supply from the uterine arteries and collaterals from the ovarian artery as well. So even if you've blocked the uterine, it's still going to get blood from the ovary, so the uterus is not going to die off.
Yes.
But because the fibroids get their blood supply exclusively from the uterine arteries, it means that fibroids will their growth will be stopped. Yeah. And that's a mode of treatment also. The newest kid on the block is something called at least in the country, it's something called HIFU. HIFU is high intensity focused ultrasound. Okay, so it uses two modalities, both ultrasound and MRI.
All right.
Okay, so they use the MRI to locate where the fibroids are, and then they're now going to concentrate ultrasound waves on the fibroid. Okay, and this helps kind of like kill, for lack of a better word, the fibroid, and the fibroid shrink. Okay, that from the people who have introduced it, they say even in women who want to conceive in the future, they can still use this modality. Okay. So those are some of the treatment options. There are many, and at least right now in Nairobi, or just to say in Kenya, all the methods I've mentioned are available. Yeah.
And are there like lifestyle or medical factors that might worsen, symptoms in?
Okay. Directly, maybe no, but I think, like with all things, things like smoking alcohol, what they do is they reduce oxygen being delivered to tissues. So less oxygen to tissues, you find things like pain would be worse. So we obviously try to say things like your coffee, smoking, those type of things you should reduce.
Did you say coffee?
Yeah. Because it dehydrates.
Okay.
Even things like sugar, anything that makes you dehydrated, you kind of like try to avoid, so that you improve circulation to your tissues. But generally for fibroids, it's just looking at, as I've said, severity of the symptoms and what are your reproductive goals, and just have a discussion on what works for you, and you come up with a treatment plan with your gynecologist.
What are some of the common myths that you've encountered
and
about fibroids?
As we talk about myths, I'll ask the question that you had sent. Someone commented, atuambie kama kweli blackstrap molasses husaidia kuua cells za fibroids.
Ati blackstrap molasses. Sasa itakuwa namna gani?
It's a myth, I guess.
That would be a very big myth.
So no.
No, it doesn't.
No, that is being peddled out there. Like there's what are some of the myths that you've encountered?
I really find, and maybe not exactly with fibroids per se, my challenge with, and I think you started with, like, say, herbal.
Yes.
Okay. And I think the most common herbal thing, not common, but I find a lot of women are using, is herbal contraception. Okay. Yes. Okay. There's something called mchina. At least one of my clients told me that in mchina. It's a It's a pill you take once a month. Yeah, vis-a-vis me who's giving you microgynon or whatever, which you're taking every day, every day. So they take once a month, mchina. And maisha endelee, next month they take another one. You understand? Now, they say it's herbal. Now, I ask the question, your periods is hormonal. Pregnancy is hormonal.
Yeah.
Then you're telling me this thing is herbal, meaning it has no... You know, the connotation behind herbal is that it is natural. It has no side effects. You know, that's the whatever. But I'm telling you, your period is hormonal, pregnancy is hormonal, and you want to tell me that you're taking this herbal preparation that's going to stop something hormonal from happening, and it's not hormonal. Does that make sense to you?
Absolutely not.
Exactly not.
Yeah.
So, and even people say our medication, okay? And I'm like, even us, our medication is herbal. From point of view, even some of the most toxic drugs, like chemotherapy for cancer, the most common are extracted from plants. So are they herbal? The answer is yes. But are they toxic? The answer is yes. So for me, I know I'm sounding like I'm really trying to bash herbalists and stuff. As I said, I don't know what they're doing, so I'm not going to dwell in it. But I think people should also just think practically and logically. And I maintain periods it's a hormonal event.
Yeah.
Pregnancy is a hormonal event. Yeah. So anything that is going to change that profile is either something that it's either hormone or it interferes with hormonal events. So it cannot be, it can come from natural sources because our drugs come from natural sources.
Yes.
You understand? So the difference between myself and say a herbalist is I will tell you, I am giving you let us just say estradiol valerate 2 milligrams, because I know we have calculated the amount of estrogen in this tablet, and it is exactly 2 milligrams. And if you take 2 milligrams of this estrogen, these are the likely side effects that you're going to have. The herbal thing is like there's no side effects, it's safe, it's whatever, it's a miracle cure. I think that you see somebody, there's one preparation in a stop fibroids, in a cure infertility, in a tafuta kazi. I don't know. The same thing, man. Okay, maybe they give different things, man. Inaongeza dawa ya nguvu za kiume.
Same dawa.
So you're like, okay.
Dr. Maureen.
Cheers. But it's okay. Yeah. So, but I think the issue, and I think if I remember, like, was it Loliondo? That guy in Tanzania during that during HIV pandemic. That guy made money.
He made money.
The difference is, because he has no ethics, you understand? For us, we're bound by ethics. And in ethics, I'm bound to tell you that this drug has this potential issues. This type of treatment has this side. So, and human beings by nature, they don't want to be told about problems. They only want to be told, this thing is great, it's fantastic, and it does everything. Okay?
So we shut down that other bit.
So you'd rather go to this guy who was technically selling air. Than come to and get conventional HIV treatment, which I think you can see today.
I mean, up by science
we're in an era. I mean, if I'm on HIV treatment, there's no difference between me and you. My life expectancy is like yours. Compared to when I started practice around 2000, and someone was just on HIV at and you feel sorry for them because it was technically a death sentence.
Yes.
So It's challenging, but I think therein lies the challenge we have as medical practitioners with the outside population is we speak the truth. Human beings do not like the truth.
Unfortunately, it's true. It's true.
And that I don't know if it's a myth or misconception, but that's one of the challenges. The challenges we have. So our ethics binds us that ideally we should inform patients of what are possible pitfalls, and the moment you tell somebody's pitfalls, hataki. They'd rather go treatment. Maybe because, as I've said, those things they have hormones in them. So because it has hormones, maybe it stopped the bleeding for some time. You understand? But you stop, you come back with worse symptoms, and then obviously they come to us. And again, some of the challenges of some of our big referral hospitals, people say that, if you go to certain hospitals, you go there to die. But why do we die? Is because you wait until really you've exhausted everything. Patient is at the last stage. What miracle at that point are people supposed to perform? Yet, had you come, received the right treatment at the right time, you'd be alive. Like, I have a very sad case, but unfortunately, it's like I have one of my aunties, and she's a very close friend to us as a family. Aside from being an auntie, she was also very, very good. She was very close to us. And she got breast cancer and opted to do this herbal. And I mean, she unfortunately passed on. And I look and I tell people, look, I know it's outside of fibroids, but I tell people, if I was to be told you have to get cancer, but you can choose a cancer you want, which cancer would I choose as a woman right now? My answer would be very, very clear. It's breast cancer. Why? Because breast cancer, where we have reached, you diagnose it early, treat it early, their life expectancy is years and years and years. I know people with breast cancer, we've had babies after, it's 20 years, 15 years, 30 years. How many cancers do you hear people have survived? 20 years, 30 years, 40 years post-fact. Okay? Agreed, I don't want any cancer.
Correct, yes.
But that's the case. So you look at, this is somebody who had a cancer which, depending on the stage it was diagnosed, actually had a chance at cure. But because of ignorance, whatever, she's deceased. I can't do anything about that now. But I feel had she opted for a different line of treatment, she may still be with us today.
Correct.
So don't fear. The issue is making hard decisions, but make decisions at the right time. It's the difference between life and death. Fortunately for fibroids, it's not that serious, but quality of life. Remember that there are two aspects. There's one, just being alive, and there's two, quality of life. Again, you make decisions at the right time, we improve your quality of life, you go about your business, na mambo ni shwari.
I know we're talking about fibroids, but other uterine conditions like cysts. Could you probably just tell us the difference? Because I mean sometimes people
get
mix
confused.
Up the two. Confused over the
so I think reproductive organs are an enigma, because I think, like Ellen pointed out, you don't see them. Huh?
Mysterious.
So cysts again will not be on the uterus. Most cysts will be on the ovary. Okay. Like if I look at reproductive issues, there are other tiny cysts like you find like on the cervix. We have something called an Abothian cyst and a Abothian follicle. The only problem with people is the moment I write the word cyst, everybody thinks you have a disease. But cyst just means a small sac that has fluid in it. That's what a cyst. You can get a cyst in almost where there's any form of epithelium. So that's your skin, gut, eyes. Just as long as there's something like any form of epithelium, you can get a cyst there. So you get nasal cysts, you get cysts in your throat, a cyst can be anywhere. You just won't get on your hair because there's no there's no cyst of your hair. So when I see an abortion cyst, that's a normal finding. It's telling me, I automatically know you're in your reproductive age. It's a factor of estrogen acting on your cervix. Okay? Again, cysts on the ovary. Do we ovulate when we're in reproductive age? See, before you ovulate, you're going to have a follicular cyst growing, and once you ovulate, after you ovulate, another cyst forms, what we call a corpus luteum, and this actually helps to maintain the pregnancy until the placenta takes over, and then it regresses. So a cyst per se is not necessarily a disease. So some cysts are physiological or just part of your normal nature, what's supposed to be happening. Then there are what we now call pathological cysts. So for us, cutoff on the ovary, if a cyst is more than 5-6 centimeters, now those are definitely a pathological cyst. And then again, you look at, is it causing any changes? Like, is it making you have heavy bleeding, stuff like that? So uterus, on the uterus, common things, pathologies you find on the uterus would be, as we said, fibroids will be the most common. Then, of course, infection. After infections, what do you call this thing? Cancer. So you can have uterine cancer or endometrial cancer. Then after cancers, rare but still happen, you have what we call congenital developmental anomalies of the uterus. So you find there are these people who have two horns. As a person has two uteruses, two cervixes, two like that, and it's just during their growth in their womb, there was failure of fusion of certain ducts that lead to the formation of the uterus. So that also happens. Then because of things that we do, so like I said, because of infection, you can get like the uterus, the lining sticks together, so we call those adhesions, and we call it Asherman's. So you find the adhesions, so it's like so the common finding is that either they have scanty periods, and in very bad cases, no periods at all. And this can be a result of infection, and can be a result of any procedure that's like to clean the uterus. So like just after miscarriages, or even for getting a biopsy, you do what is called either DNC or MVA. That's just to clean the uterus. In some cases that can happen, or infection.
Okay. Whoa, this is quite the masterclass.
The masterclass.
Doctor, we don't have that much time. But,
sure.
I'm getting a question from someone. They're saying they have 3 teenage daughters, and they're asking if there's anything they could do to reduce the risk of fibroids in anything, maybe the cyst or anything. And maybe you could just give us your doctor's advice for how we can handle this situation for our young children, for ourselves who are at the reproductive age, and
so I think in terms of reduction of getting fibroids, as we said, for everybody, the normal things, smoking, alcohol, don't do, but passe for fibroids, it's how do we encourage the young population, you understand, to exercise their reproductive rights at the right time, because again, we're at an age whereby everybody's being told go to school, which is a very good thing. I'm not saying do not go to school, but there's a reason why God made you to be more fertile in your 20s than say your 40s. I don't think there's anyone who's more clever than God. For those of you who don't believe in God, forgive us. But for us, personally, I believe in God, and I'm going to profess that way. So there's a reason God, and for those who don't believe, your physiology made you to be more fertile in your 20s rather than in your 40s. So the conversation we should not be having, because the problem is with education, all of this, girls are putting off giving birth to further their careers. Okay? So I want to be a marketer, I want to become a marketing manager, I want to become a CEO before I get married, okay? And then have my kids. By the time all that happens in your 40s and your fertility has dipped. I'm not saying you cannot have children in your 40s. What I'm saying is that it's much, much harder to have children in your 40s. Why do you want to struggle conceiving when at this time it's almost free for all? Okay? So the conversation we should have with young people, because again, I'm a believer in the family unit.
Yes.
Okay? Is how do we encourage them, you understand, to get married or start living together at least, so that they're expressing their reproductive potential at the right time.
Okay.
And I think it's a very difficult topic because there are so many sideshows. But what I want everyone to remember is you can become rich at 10 years. So there's some 10-year-olds jemeandika kitabu na ni billionaire. Okay? Sasa you can become a billionaire in your 70s. You understand? But naturally, you understand? Your reproductive lifespan is only at a certain window.
Yes.
Okay? Utilize your window at the right time.
Okay. Wow.
And that would prevent fibroids.
Well, that was Dr. Maureen Owiti taking us through the masterclass. Dr. Thank you so much. We're going to be seeing you soon.
Hope so.